All right, I'm super excited to be here today. We're going to talk about empowering equitable access to cardiovascular care. This talk is going to be focused primarily on the US and on cardiovascular care. I have no disclosures. The objectives of this talk are to define the burden and disparities in cardiovascular disease, describe the US healthcare ecosystem, identify barriers to accessible cardiovascular care, and discuss strategies to improve access to cardiovascular care. All right, so we'll start with definitions. When we talk about access to healthcare in general, it's defined by the National Academy of Medicine as a timely use of personal health services to achieve the best health outcomes. So there's a lot of emphasis on the timely nature and also achievement of best outcomes. So cardiovascular disease is very common. It increases as we age, as you can see from the figure below. It's more common in men compared with women. It's also more common in patients who have hypertension compared with patients who are not hypertensive. And with any given combination of age, sex, presence of hypertension, the prevalence could vary anywhere from 1% to 86%. On average, it's almost about 50% in the US population. It's number one cause of death. And it accounts for about 12% of total US healthcare expenditure. Trends over time are not promising. There's increasing prevalence and also increasing mortality from CVD disease in the US. Disparities are something that's well known to you, more commonly understood as it relates to race, ethnicity, age, sex, gender, or sexual orientation. But more increasingly, we're recognizing that there is a lot more to disparities than this. There are geographic disparities between rural and urban areas, socioeconomic factors that contribute, etc. And there's a wealth of data that support that disparities are associated with increasing burden of cardiovascular disease, risk factors, cardiovascular disease, access to care, quality care, and worse outcomes. There are a lot of missed opportunities in the way that healthcare is accessible. So, reduction of risk factors for cardiovascular disease can reduce cardiovascular disease incidence by 80%. Let that sink in. 80% reduction in cardiovascular disease by addressing risk factor. So not only for risk factors, but there are missed opportunities along the spectrum of cardiovascular disease. Not activating the patients and not engaging the patients in discussions regarding their care. Failure to diagnose patients with pre-existing cardiovascular disease. Not using first-line guideline-directed medical therapies or advanced therapies. And in my area of work, heart failure, again, a missed opportunity. Only 5% of the patients with heart failure are offered palliative care. Again, let that sink in. So there are huge opportunities to improve access for patients with cardiovascular disease. And let's just take a step back when we talk about this. This is a 10,000-foot view of the US healthcare ecosystem. And what is the take-home message from this slide is a complexity of the US healthcare. So it involves different sectors, public and private. The government is front and center with policies, government-based insurances, etc. Facilities that include hospitals, pharmacies, long-term facilities, others. And the workforce was physician and non-physician healthcare professionals. Technology is very important. This includes biotech and also includes medical record systems, digital health, etc., research and education. So it's a very complex system, and there are different aspects to it that impact access to care. as regards to cardiovascular care, we could divide this into 4 domains. And I gave them the 4 Ps for policy, payers, providers, which in this context refers to where healthcare is provided. So this is the healthcare systems or other facilities and the workforce that provide the healthcare. And lastly, but not least, the patients who should be the center of what we do. And patient factors or barriers that contribute to healthcare are complex and best summarized in this figure of social determinants of health. So some of these are things that are related to medicine, but a lot has to do with other social determinants of health that are outside of what we do every day, but extremely important to address when we talk about access to healthcare. So we talked about the magnitude of the problem, the barriers. Now let's just talk about some solution, because I think this is the part that may be more interesting in this talk. And it may feel like daunting to come up with solutions for this, but there is a lot of hope. So the first P is policy. Healthcare policies are extremely important. So implementation of preventative services, as I talked earlier, we could decrease cardiovascular disease by about 80% if we address risk factors. Healthcare coverage, there have been different reforms. Most recently, the Affordable Care Act, there are also different provisions in different acts that address healthcare coverage, prescription drug coverage, the workforce, etc. So healthcare delivery models that are patient-centric, we throw a lot of adjectives about what ideal healthcare models should be, but whatever we do should be focused on the patients and their outcomes. Funding for biomedical research, this will help us understand more what we do and do it in a better way. The second P is payers, affordable plans, expansion of coverage, and broadening of the networks. Providers is a third P for healthcare system, providing high quality, high value, equitable care where quality, which is part of value, do not exclude equity. Effective, scalable, and sustainable systems to take care of patients, and expansion of services and utilization of telehealth. For the workforce, recruitment, diversification, retention, and focus on the well-being, fair reimbursement for physician, and development of cultural competence for the staff that cares for our patients. The fourth P is patients, education, advocacy, and community-based resources and social support for the patients. I want to highlight a couple of things that worth discussing is the physician shortage, not just a physician, but the whole workforce shortage that has been uncovered by the COVID pandemic and is expected to worsen. So it's extremely important for us to understand that about 40% of the active physicians will likely retire within the next decade, and this will leave a deficit that ranges from anywhere between 37,000 to 124,000 physicians. So this is a significant area of unmet need for the future. Second is the role of technology and access to care. There is a lot of advancement in technology. It's unclear what the role will be. There is a lot of hope for utilization of technology to bridge gaps in access to healthcare. There's also a lot of caution as to how that may work and whether it will do what it's intended to do. Lastly, I want to share a couple of strategy-based clinical trials that use innovative approaches to improve access to cardiovascular care, just to give an example of what could be done. So this trial is a cluster-based, it essentially targeted Black population, specifically men who have hypertension, and met the patient where they were. So it went to the barber's shop where these patients have received their services and randomize them to usual care versus pharmacist assistance. And this showed significant improvement in blood pressure when they reach out to that population in their barbershops. And this basically a strategy trial that included going to non-traditional healthcare setting, engaging with trusted community partners who are the barbers, and also extending healthcare by including a pharmacist who prescribed antihypertensive medication. And it showed significant reduction in blood pressure. About 2/3 of the patient achieved goal blood pressure as compared with 10% in control. The second trial was more of a policy trial. It's an old trial, but it's very relevant today. And this trial targeted full prescription drug coverage for patients after discharge from an acute myocardial infarction hospitalization. And it randomized insurance plans to full coverage versus standard coverage. And it showed improvement in adherence to medications. It did not reach its primary endpoint, and that's for various reasons. However, it did not increase the overall spending, suggesting that it's doable to improve coverage while not increasing spending. So in conclusion, equitable access to high-value CV care leads to healthier communities and decreased expenditures. The US healthcare ecosystem constitutes a complex interplay among various sectors. Barriers to accessible cardiovascular care exist in 4 domains. We talked about policy, patient, provider, and payer. Strategies to improve access to care are an unmet need and require a multifaceted approach. It's the call to action as I finish this talk: compassion, emphasis on prevention, early diagnosis, and early referral, innovative care delivery models, empowering interdisciplinary teams, development of effective systems, leveraging technology, community partnership, and promotion of the well-being of the workforce, and advocating for equitable patient-centered care. Thank you very much for having me.